Hi, everybody. I'm so glad to see everybody coming together and making connections. However, if we can start taking our seats again, please, for Dr. Zegris's next presentation. Thanks, everybody. Just within the next minute, we're going to have our next speaker come up. If everybody could still start taking their seats, that would be fantastic. Thank you. Not good. Perfect. I know. There you go. Perfect. Okay, that's not the fire alarm, I promise. But just again, and a reminder to get going as we are running a little bit behind as well, too. Thanks, everybody. Okay. All right. Thank you, everyone. I hope that you had a nice break and had a chance to connect with colleagues. And we will now get to our next speaker. I have the privilege of introducing Dr. Zegris, who is a gynecology oncologist at Trillium Health Partners, Credit Valley Hospital. She completed her OB-GYN residency and training at Yale New Haven Health, Bridgeport Hospital in Connecticut, USA. Thereafter, she completed an MSc in clinical epidemiology through IHPME at University of Toronto and completed her fellowship in gynecology and oncology at the University of Toronto. She is the assistant professor and Department of Obstetrics and Gynecology at University of Toronto, Temetry Faculty of Medicine. She is the provincial lead, her brand new role, we're very proud of her, the provincial lead for the Ontario Cervical Cancer Screening Program and colposcopy. Prior to this, yes? One of our own from Mississauga, so we're very proud of that. And prior to this role, she was a regional lead for cervical cancer screening. So she went from the regional role to the provincial role. So she has an interest in cancer prevention, HPV infections, and cancers of the lower GI tract. I am absolutely honored to welcome Dr. Zegris.
Thank you so much, and thank you to everybody for joining us this morning. This is, as Scott mentioned this morning, one of our proudest meetings that we hold every year, and it is very, I don't know how to say it, like sentimental to be, from the region and your kind of regional lead for a few more days, and also now moving into my provincial lead role. And so I've learned so much from working in the region, working with all of you primary care physicians, the partners, the regional cancer program, and I'm taking all of those learnings and using them in my new role. So thank you so much for all the mentorship up until now, and I hope that maybe I might be invited back in future. We'll see. But today I'm here to speak to you guys about some of the updated data on the rollout of the HPV program. As you all know, we launched in March of 2025. So we're going to be speaking a lot about the data since the rollout. Just a few reminders about the program, and also I think what a lot of you are very interested in is the self-collection portion of the program. So I do have some disclosures. As part of my work as a gynecologic oncologist, I have received some honorariums from some of the pharmaceutical companies for talks that I've given in the past. All of them are completely unrelated to screening. I also have received a stipend as in my regional lead role, and also received a stipend for my provincial role. We've also received some in-kind support from Ontario Health in helping to prepare these slides, so thank you for the help with preparing our slides to the program, to the team from the Ontario Cervical Screening Program. Just some obligatory slides here. We can move right through. So these are our objectives. So as you guys know, cervical screening, the whole goal of screening is to try to identify and detect abnormalities long before they become some larger problem that we have to deal with. And anecdotally, we have seen in our oncology practice that cervical cancer is on the rise. You guys have maybe seen this in the media recently. There was a big actual push about this in the media in the recent months regarding the rise that we're seeing in cervical cancer despite all of our efforts in screening. And so this is obviously very alarming to us as oncologists. I think it's alarming to probably you as family physicians if you see that your patient had a positive HPV test and then suddenly you saw that they had a diagnosis of cancer after they've been seen in colposcopy. And of course, I think that we're all going to be part of the solution here. We do know that cervical screening does make a difference. We have about 4.5 million eligible Ontarians who participate in screening. And about 600 will be diagnosed with cervical cancer per year, and about 150 will die from it every year. Most cervical cancers are found in people who are under or never screened. And again, I think we're quite unique in this population, in the region where we work, because we have a large population of newcomers to Canada, immigrants to Canada, people who've never participated in screening before. And so, I mean, in my practice, I've seen a lot of, 60 to 70-year-olds who are diagnosed with cervical cancer because they've never been screened before. It was just not part of what happened in their former country. So screening does save lives. It does make a difference. And again, you guys are all part of that process. So March 2025, we launched the HPV test as our primary test for cervical screening. As you guys probably know from doing this every day, that it's a HPV test, and if the HPV test is negative, then there's no cytology. If the HPV test is positive, then you get a reflex cytology. You also get a reflex genotype of the HPV, which helps us to triage the management of those patients. We're going to go through that a little bit more detail. All of the tests that are performed, all of the HPV tests are now being performed by procured labs. So in the past, you maybe sent it to Life Labs or DynaCare or some other kind of lab that you were sending to, but since the launch of the HPV testing, it's all under kind of a lab service provider that's procured by Ontario Health. And that actually helps us a lot with kind of data collection, figuring out where things are maybe going wrong in the program, and really helps with our data analysis aspect of the program. And also, I guess, in terms of requisitions and clarity on reporting and things like that, that's also a big component of the program. So as you all know, we've moved from a cytology-based test, which actually has a pretty poor sensitivity. I'm always, the medical students are always shocked when I ask them, like, oh, what's the sensitivity of a Pap test? And they're like, I don't know. I was like, this is kind of around 50%. Like, that's not a really great test. So that's why you had to do it so frequently, because its sensitivity was so poor. Now that we've moved to HPV testing, which has a sensitivity that's closer to 95%, it's a much more sensitive test, it's a higher performing test, and therefore we can do it less often. So that's why the move to 5 years. And so I think that's a question that probably comes up. I see it in my colposcopy clinic. I'm sure you guys hear it from your patients. Is it safe now that I moved to every 5 years? Before it was every 3 years, and before that it was every year. And yes, it is. It is very safe. In fact, data out of BC that they've moved to HPV testing a year or two before us shows that a negative HPV test probably has its kind of its length of like being certain that it's negative is about 7 years. So it could even be beyond 5 years. But of course, 5 years is where we feel comfortable to repeat the testing. HPV detects the virus that causes the cancer. And that actually has led to us finding a lot more diagnosis earlier, because people who come in with HPV positive test but a negative cytology, we've diagnosed quite a few with cancer. So it's already showing the power of the program that we've changed to an HPV test by finding diagnosis earlier, finding high-grade lesions earlier in the cervix because of the power of the HPV test compared to cytology alone. So I feel like already in 1 year, I feel like it's been a great success because we have been finding a lot more earlier abnormalities. With self-collection as something that we're going to talk about later, and I know everybody's really excited about, patients and providers, that wouldn't have been possible with cytology, but it is something that's possible with HPV testing. So it was very important that we made this change, and I think that probably you guys feel it in your practice, and I definitely feel it in colposcopy, that having that change to HPV has been a huge quality improvement for the program. Okay, so just to remind you, again, you guys probably all know this, you need to be at least 25 to participate in the screening program. It was kind of a soft launch during COVID that we asked you to please start shifting the screening towards 25, but it wasn't kind of a hard and fast, like, it is 25. It was still kind of written there, 21 on some of the websites. So as of March 2025, the starting age is 25. Again, that is incredibly safe. Very few people will be diagnosed with a cervical cancer before 25 years old. If they are, many of them are non-HPV related. So it is very safe for us to start at 25. Even some jurisdictions will start at 30, but we're starting at 25, and I think that's a good kind of compromise. They have to have been sexually active. Remember, that's not just penetrative intercourse. That can be if maybe they've done some other sexual activity, sharing of sex toys, oral sex, things like that can be considered sexual activity. They should have OHIP coverage. And again, I know in our region this is maybe a little bit of a struggle because we have a lot of non-OHIP patients, but to be part of the Ontario Cervical Screening Program, you do have to have an OHIP card. And you should be asymptomatic. We'll talk a little bit more about that in the future slides. With the move to HPV testing, we've also moved to a kind of a risk-based algorithm. So if you are average risk, meaning that your HPV is negative, you repeat in 5 years. If you're in this immunocompromised kind of gray zone, we're asking you to be screened every 3 years. So what does immunocompromised mean? Anybody who's had a transplant and is on immune modulating drugs, they need to be screened every 3 years. Now this can get a bit confusing, and our lists are not extensive because there are so many new drugs that are coming on the market. Again, even in my colposcopy practice, sometimes you ask a patient their medical history and you're this drug sounds a bit weird to me. What do you take that for? Oh, I take it for my Crohn's disease. Okay, is this affecting your immune system? And so, then I have to go and look it up. I'm like, okay, you need to be screened every 3 years. So I don't have a kind of clear list for you of every single drug that counts. You kind of have to just double check some of those immune modulating drugs. You consider that every 3 years and just make sure you check off the right box on your requisition form. Moderate risk every 2 years, and we'll talk about who those people are in a second. And then if you have elevated risk, so anybody who has HPV 16, 1845 or an HSIL or ASCH or cancer kind of PAP result, they need to come into colposcopy. So this is the algorithm. I'm sure you guys are all very familiar with it. It just basically goes through kind of in an algorithmic form our recommendations that if you have HPV negative, it's every 5 years, or as mentioned, if you're immunocompromised, every 3 years. If you're HPV positive for 16 or 18 or 45, it's very easy. Just send them to colposcopy no matter what. The gray zone is where you have people who are HPV other, and then the recommendation is going to rely on either the cytology or also their previous result, which we can also talk about a little bit more in a bit. But if the PAP result from HPV other is HSIL or ASCH, or again, anything that's like AGC or anything that's not ASCUS or LSIL, basically anything that's not ASCUS or LSIL, refer to colposcopy. If they have a normal ASCUS or LSIL cytology result, they go into that moderate risk category and can be rescreened in 2 years. Those people have about a 5% chance of having, or even less than 5% chance of having, something on their cervix to treat immediately. A lot of times they will clear their HPV on their own in the next 2 years. And when they come back in 2 years, if their HPV test is now negative, they go back to every 5 years, back to that average risk screening. If they come back and their HPV is still positive, now they're bumped into that elevated risk category and they need to be referred to colposcopy. Okay, so what happens when they come into colposcopy? So if they're referred with an HPV other that was normal, ASCUS or LSIL, and we look at their cervix and we don't see a high-grade lesion, then we're going to discharge them immediately back to you and ask you to repeat the HPV test in 2 years. So still in that moderate risk category. On the requisition, there is a box to indicate that, and that's what we want you to check off when you're ordering the test, because that will help inform your recommendations for the referral back to us. So if when you do the HPV test 2 years later, if it's still positive, they actually do need to come immediately back to us. They don't need another one 2 years later. If they come in with a referral with HSIL or ASK-H, if we don't see something to treat, we will actually keep them in colposcopy and see them again 1 year later, make sure we haven't missed something. If at that 1 year later we still don't see something, we'll discharge them back to you again to repeat in 2 years. Unless if we tested them HPV negative, we might just say, okay, 5 years is fine. So you should get instructions from the colposcopist with respect to when the next cervical screening test should be done. If we do identify a high-grade lesion, then we're going to treat that. It's going to either be a LEEP or a laser, usually a LEEP, and then they'll follow a LEEP algorithm where we see them 2 more times before we discharge them back, and then again we'll give you instructions, whether that's 5 years or 2 years, depending on if they exit with an HPV positive or HPV negative test. And if we happen to detect cancer in colposcopy, they will exit to the oncology program. Okay, I think that's it. So we wanted to give you some of the data from the last year of implementation that we thought you might be interested in. So in terms of participation, for whatever reason, we've been seeing a slight decline in participation. This has been also true in the FIT testing, that we've been seeing a bit of a decline in participation. And you know, this may have multiple factors as to why this is, but certainly, you know, I think, again, you guys are definitely part of the solution. And Baldeep did tell me that starting on April 1st, there's going to be some new billing code for completing a cervical screening test. So once we have that information, we'll be sure to circulate that to you. But definitely there's been a bit of a decline. Our target is 60%, which to be honest is probably low. Like, it would really be nice if we had even more participation. Honestly, kind of when you scan multiple jurisdictions, I don't think too many get much higher than 60%. Probably in Australia, they're maybe getting about 70%. They also have a really organized screening program. But 60% is our target, and we're falling below that at about 57%. In our region in particular, we usually do actually quite poorly on this indicator. In Central West, we're about 54%. Mississauga-Halton's only about 55%. So we're always, the regional cancer program is doing a lot of work, and the team is working a lot with partners to try to get the word out there about cervical screening to some of our newcomers, immigrants to the country, Indigenous people. We're really trying to work hard to get the word out to patients and do as much as the regional cancer program can do, but certainly we do need you guys to help as well. With respect to how many screening tests we've done, it's almost been 1 million since the start of the program, just shy of 1 million. You can see that from March until February, there's been quite a few. There's a bit of a seasonal dip in July and August. I guess less people come in for their screening tests. Maybe they're away for the summer, a little bit of a dip in December, January, but otherwise pretty consistent numbers that people are coming in to screen. You see that there's not too many being screened between 21 to 24, which is what we want to see. There may have been some lingering people who had screening done in the prior program, and then maybe they've come in for follow-up. So there are a couple that are trickling in between 21 to 24, but the vast majority are in the target age range of 25 to 69. And so what have the results been? Well, actually, the vast majority of people have a negative HPV test. So 93% of people will have a negative HPV test and fall into the average risk category. And then about 7% will fall into either the moderate or elevated risk. Most are moderate risk, about 5%, so they need to be rescreened in 2 years. And then about 1.5% are elevated risk, meaning they have HPV other with a high risk cytology result and need to be referred in, or they have HPV 16 or 18/45 and need to be referred into colposcopy. Very few are invalid test results, so that just again speaks to the performance of the test. So again, here you see almost 1 million since we launched in March of 2025, so pretty impressive. With respect to rejected cervical screening tests, you can see when the program launched in March of 2025, we had almost 5% of the specimens were being rejected, and we'll go through the reasons why in the next slide. Over the last 6 months, that's stabilized to be about 1.5%. So we're definitely getting into kind of program stability here, that people are kind of figuring out what's the right thing to do and how to do it. And we're definitely, as we learn more things, we're sharing them with you guys, but definitely getting into program stability. And so why are we rejecting samples? Well, when we first launched in March of 2025, it was a lot because of the broom being left in the vial, because that was the previous test for a lot of people. But since then, a lot of people have kind of figured that out, and now that's a lot less of our samples as being the reason for rejection. Now it seems that having a leaking vial seems to be more of a common reason. So the medium is kind of spilling out because the lid isn't on properly. We've been hearing from the lab that kind of plastic wrap around the lid, if it's not kind of completely off, the lid might not screw on properly. So maybe just make sure that comes completely off. I mean, I think about how many times my water bottle has leaked in my lunch bag, and then I can kind of relate to, like, sometimes you don't screw something on properly, but, if you don't want your patient to come back to have another test, if make sure that lid is screwed on properly. And then, of course, making sure things are labeled properly and making sure that the medium is not expired, and also that the specimen is not sitting in your office for too long, because that can be another reason why it might be rejected, although that's very few of the sample rejection reasons. And then also with respect to the requisition, there might be some reasons that the sample gets rejected. When we launched in March, there were very few rejections, but now you can see that the rejections are getting higher. Specifically in February, you see there's quite a bit of a spike. One of the reasons is because people are being rejected because they're being screened too soon. So that could be because maybe providers or patients are not trusting the result and they want to be rescreened. But if you are being screened outside of the recommended interval, the lab will just reject it. And sometimes we know patients are also going to another provider, so they might not be coming back to you. They might be going somewhere else and trying to get it done, but that test is going to be rejected. Also, if they're not meeting the age eligibility, they'll be rejected. And so just trying to reinforce the idea that this is a very high-performing test. It is very safe to repeat at the recommended interval. And again, it's a screening program, right? We're trying to balance the risk-benefit of like the harms of screening versus benefits, and we know that over-screening can also cause harm. So some requisitions are missing the right test indication. Sometimes the lab will try to reach out to you to find out the right indication if it's missing on the box. I mentioned this earlier, but it's really important to know that the recommendation you get on the results report is related to the test indication. So if you put the wrong test indication, you might get the wrong recommendation. Because the lab kind of knows the algorithms, and again, that's something that we partner very closely with the labs to make sure. So the test indication is super important. Again, if they don't know, if they can't reach out to you and get that right information, which you can see in yellow, those are the ones that the lab was able to reach the provider and correct the indication. But if they don't know, they're just going to go ahead with the average risk and check that off if they can't reach you or get that response from you. And then that would, again, influence your result and action that you need to take. So this is just, again, showing you those test indications and why they're important, the average risk, if they're immunocompromised, if they were HPV other before, so in that moderate risk category, if we discharge them from colposcopy and ask you to rescreen in 2 years, that has its own box. And then for people who had a hysterectomy and they had some kind of a cervical cancer or dysplasia, they can have a one-time vaginal vault test, just one time. In my practice, I've been trying to keep those people in my own practice and do that test, so hopefully that never falls on you. But I can't say that that's true for all the gynecologists, in Mississauga, Halton, and Central West. So, if that is the case, they can have just a one-time HPV test. If that test is negative, they never need to be screened again. If it's positive, they need to be referred to colposcopy, and that's kind of where the guidelines end, and then it's kind of up to the colposcopist to decide how are they going to follow them and monitor them, and it's kind of out of your hands at that point. And then for some people, if they have an HPV test that is other and the cytology has come back inadequate or something, you might have to bring them back for a cytology only. So that's the only time we want you to be selecting cytology only, is if for some reason on that HPV other and it came back as inadequate. If it was 16 or 18, you can just refer them directly to colposcopy even if you didn't get like a cytology result, because we'll see them in colposcopy. So just a brief reminder that some people have been trying to order the cytology only after they have a negative HPV test. That's really not needed, and so we just kind of wanted to remind that this is a test that's being done for cervical cancer screening. I know that in the past sometimes we did pick up some atypical endometrial cells or something you might have found, like an endometrial cancer rarely, but that's not the purpose of the cervical screening test. The cervical screening test is meant to detect abnormalities related to the cervix, not other gynecologic cancers, right? We don't have screening, unfortunately, for uterine cancer or ovarian cancer. And so trying to get a cytology-only test because maybe there might be something else going on is not going to be helpful. And also, if you're worried that you might be missing something because they were HPV negative, and what if they have a cancer that's HPV negative of the cervix? Well, those are quite rare. They're very rare. They're not very well understood, and an HPV test is not going to be the thing that's going to pick up an HPV-independent cervical cancer. Like I said, they're quite rare. Most cervical cancers, like 98%, are related to HPV. So the lab will reject those too. And just a quick reminder about people who are symptomatic. So again, screening is for the asymptomatic patient population. So if someone comes in with postcoital bleeding, or when you go to do the cervical screening test, you see a lesion on the cervix that you're worried about and you think maybe there's a cancer there or a tumor, now this is like a symptomatic patient. Other signs of cervical cancer can be back pain, can be one side, leg swelling. If there's a really big tumor, can cause compression to a ureter if there's a big tumor there. The other thing I would say if you're very worried is also like placing your hand in the vagina and feeling the cervix. I can't tell you the number of times like you just put your hand in the vagina and like for me and I feel, oh my God, I know that's cancer, because it just feels so odd. So if you're really not sure, putting your hand in, and then when you need to refer those patients to see somebody, either to colposcopy or to a gynecologist in your area. And you want to be really clear about what your concern is. Like, I'm worried about cervical cancer, or this was postcoital bleeding and I saw something on the cervix, just to really help get that referral in. And I know I was at another meeting last night where there were family doctors, and one of the family doctors came up to a group of us gyne-oncs and was like, what are we going to do about gynecology in Mississauga? They're not accepting our referrals. And so we did give him some advice. So we hope to, we hear you, because I'm a gynecologic oncologist. So sometimes we also have problems when we're like, well, this isn't gyne-onc, this is gynecology. But anyway, I know it's hard. I get it. I hear you. But they do need to be seen. So, you can try also referring to colposcopy if you're worried about cervical cancer. That's very appropriate. And we will see them if you're worried about cervical cancer. Okay, so what about the follow-up of those abnormal tests? So we do look at that as a program, and what we've been seeing is actually since HPV launch, those people that are falling into that elevated risk category, we've actually seen like a rise in the kind of no follow-up over 6 months. So we want them to be seen within 6 months, but we've been seeing that for some reason, we're not actually getting people in a timely fashion. When we've done a bit of a deep dive at the program into why this is, it looks like it's largely related to people who were previously screened annually or had an LSIL or an ASCUS last year, and now this year have an HPV other and maybe a normal cytology. And it could be kind of one of two things. Either maybe it's not being kind of written on the report to refer to colpo, and so they're not being referred to colpo. But we've also heard, and actually Dr. Benson Wenzel and I talked about this last meeting that we had. Sometimes colposcopy is inappropriately rejecting these. And so that's a bit of a problem. We know it's a problem. We've recognized it. And we are kind of working to get some communication out to the colposcopy clinics, also to the family doctors, and just also trying to reinforce it here today that people who last year or a year before had an ascus or LSIL, and now they come in for their next test and it's HPV other, those people now are bumped into that elevated risk category. So we think this would be a bit of a transient problem, right? Like once we get a few years out, we're not really going to have too many of these people hanging around anymore, but definitely those people need to be referred to colposcopy. And this just kind of outlines that a little bit more about what was their previous screen. So if they had an ascus or LSIL in their last year test, even if it was an ascus LSIL, then normal, and then they're coming back for like their annual screen, or if let's say they were discharged from colposcopy and we told you screen them annually, and now they have an HPV other, those are people we want to see in colpo. Okay, so what about self-collected? This is the part you guys are all waiting for. So Ontario Health does definitely recognize that there are definitely benefits to self-collection HPV testing as an option for our patients to reduce barriers to cervical screening and to hopefully increase participation. So when the program was launched last year, there was a pilot that was launched for HPV self-collection kind of alongside. This pilot launched at 11 primary care sites across the province, and then this March of 2026, another 11 sites were added on. So we do have a site in Mississauga, and it started in one of their clinics. I think it was the Somerville Family Health Teams, and they've now expanded to a few more of their own sites, so that now we have a couple more sites that are offering self-collection as an option to patients in Mississauga. And this is being, like I said, offered as an option. At the moment, it's an in-clinic test. So they come in, they see their provider, and the provider is offering it to them. Like, you can either have me collect it as the provider, or if you like, you can do the self-sample, you can do the swab yourself, go into the bathroom, collect the swab. The program selected to go with a test that is Health Canada approved. You have to resuspend it quite quickly. So that's why it has to be, at the moment, that's why it has to be collected in the office. So that the doctor or a nurse in the clinic can take that specimen and then put it in the medium and resuspend it, and then that gets sent off to the lab. And so of the people that were offered self-collection in 2025, about 26% chose the self-collected option over the provider-collected option. The clinics that have been selected across the province represent a wide group of people, so there's a bit of an equity lens on this, looking at selecting sites that would represent Indigenous health, Black health, Francophone population, the 2 SLGBTQIA2+, and also rural and northern clinics. So they did really look across all the regions in the province. They looked to the regional cancer programs to try to help identify the appropriate clinics, and that's how we selected the sites. So just a brief reminder that a provider-collected test will allow you to get the HPV test, but also allows for the cytology at the same time. So you can do a reflex cytology on that. But with the self-collect, you cannot do a reflex cytology test. You can only get the HPV test result, and because this is mostly collecting cells from in the vagina. The algorithm for self-collect is slightly different. Anybody who has an HPV test result, it's recommended at the moment that we bring those people in for a provider-collected test and then make the referral to colposcopy based on the provider-collected test result. If your HPV is negative, we are recommending that those people come back in 3 years instead of 5 years, just because this is a relatively new test. There's been some meta-analysis data that has supported this. I know the ASCCP recommended 3 years. This speaks a little bit to the guideline confusion that was spoken about in the previous talk. BC went with 5 years. When we expand this kind of more full scale, we'll see where we land. As we're learning and we're just introducing it in the province, we went with 3 years. And I think that was a very safe recommendation to go with. We don't want to provide people with a substandard option, and we will look at our data and continue to monitor our performance on this as we go through. So if you do offer your patient a self-sample, if you're doing it as part of one of the pilots, it's every 3 years for the moment. And so what have the results been for this? About 92% of people will have a negative HPV test, and then about 8% have an HPV positive test, and so need to come back in for a provider-collected test. So you can see that many people won't need to come back for that provider-collected test, which is great, but some definitely do, and that's part of the counseling that takes place with the patients. When we've looked at some of the demographics, we've been evaluating, the program has been evaluating through surveys and other qualitative evaluation of the pilot program. About 50% are within the 45 to 64 age range, and about 50% have been never screened or under-screened. And so that's where, again, this is probably a very powerful test that maybe somebody who never had screening before in their life because of maybe trauma, fear, all these things. Think about, a transgender patient who would feel very uncomfortable. Then self-sample is definitely a way to decrease those barriers. And so some of the early findings from some of the quantitative results that we've been investigating in these patients, about 93% have felt that they received good information from their healthcare provider in choosing a self-sample. 88% felt that they had good patient resources, so the program put a lot of work into the resources that they developed to help support the pilot. And 90% suggested that they had a positive experience and that collecting the sample was quite easy. Having said that, there have been a few anecdotal cases where people maybe sampled the wrong place or there's, confusion. So, there is obviously a need for resources and education around even self-sampling. And just again, from some of the overarching themes from some of the evaluation that's been done, there were focused interviews done for both the providers and the participants who have participated in the pilot. And they've mostly suggested that maintaining a choice for patients is very important. So a lot of the patients did say they liked having the choice. Some of them, depending on the pilot site, some were actually letting the patients know kind of ahead of time, like you're coming in for your cervical screening test today, you might have the option to do it as a self-collect, and people seem to like that, to have that kind of advance notice compared to people that came in and they were just like, oh, you can do a self-sample, and they were like, what? And didn't really know much about it. So some patients appreciated that kind of heads up. People did feel that the resources were very important. Both patients and providers really felt that that was key to the success of the pilot. And one other thing that has kind of come up in the provider conversations is that, while we move towards self-collection, we also have to think about how do we mitigate about some of those risks. So if we move towards a full self-collection, then what about how will providers upkeep their skill in pelvic exams and cervical exams, and that would maybe be something that might be lost along the way. So just making sure that we mitigate possible risks of implementation as we kind of move through. So kind of next steps are that we will look to expand these pilot sites and also develop kind of operational model for how would a self-sample collection option look in the future. This is being looked at. I'm sure someone's going to ask me a question about when, and I might just preempt that and say I don't know exactly when yet, but we are looking to roll HPV self-sampling out as part of the program in the coming years. That's the best answer I can give you today. And so as I kind of retire my old hat from the regional lead, I wanted to just touch on some of the work. I know Gul mentioned this earlier in her presentation, but as I mentioned, the Regional Cancer Program has been doing a lot of work in screening across all the different types of screening, but in particular in cervix screening is where I worked with the team very closely. And what we've realized as we launched HPV is that patients were coming in and and I'm sure you guys see this too, they're very freaked out about their HPV positive result, and they really don't understand it. They don't know where they got it. They don't know who gave it to them. They don't know if their husband's cheating on them, and they're very freaked out. And we felt that there was a need for some increased education around this, and so as part of a QI study, we put together this kind of QI initiative where we introduced a survey into our colposcopy clinic where we were asking patients about, what background knowledge do they have about HPV and colposcopy and a LEAP and things like that. And then we developed these resources, and these resources were really developed, again, with the themes that were spoken about this morning with co-design. We developed the scripts. We took the scripts to our community partners who are here. We circulated it to them. We asked them what they thought about our scripts, how was the language, anything else to add, and we ran it through ChatGPT and asked it if this was a grade 5 level, or actually grade 7. I think we picked grade 6 or 7, and then put together these videos. Now I'm a little embarrassed because it's my face on all of these videos, and I can't really watch them very well because it's me. But we did create these videos as a resource for both you and the patients, around kind of what is HPV, how is it spread, what's new with cervical screening in Ontario, what is colposcopy and why do I need one, and what is a LEAP and why do I need one. And the idea is that we will, from our colposcopy clinic, start emailing these to patients before they come to our colpo clinic, so that they have a resource before they even come in. And we're hoping this will help decrease some of their anxiety around colposcopy, maybe answer some of their questions. And then we have kind of a post-implementation survey, which we're just in that phase 2 now, where we're going to start emailing these videos out. But they are now uploaded to our YouTube channel, and they will be on our website shortly. And so you can definitely start using them. And so that basically wraps up what I wanted to say, just to make a few kind of key reminders that HPV testing is a very sensitive test, and doing it every 5 years is very safe, and that our participation rates are below our targets, particularly in our region. So we do have a lot of work to do, again, working with our partners, working with you in trying to get this participation rate higher. And that we're expanding self-collection, and we look to introduce it more into the program in the coming year. So stay tuned. I'm sure I'll be back to talk about it when it's fully implemented. And just reminder to please correctly identify the right test indication, as that does impact on the recommendation for what to do next, and not to leave the broom in, which I'm sure no one in this room is doing, but also to make sure the lid is closed tightly and labeled properly. And if you do try to sample outside of the screening window, it will be, unfortunately, your test will be rejected. And ordering a standalone test will also be rejected. And anybody who falls into that elevated risk category should be referred. And that elevated risk category, now it's, there's a lot more people that we're considering elevated risk and that we need to see within that kind of 6, ideally sooner, but from a province level, we look to make sure people have been seen within 6 months. But anybody with an HSIL or ASK-H, we want to see them, within 4 to 8 weeks, ideally. And then anybody who had that history of annual cytology-based and now have a first HPV test, they do need to be seen in colposcopy. So if you are getting that rejection for whatever reason from the colposcopy clinic, you can send me an email and I can, make sure that it gets booked in, because sometimes it is nurses who are doing the triaging in the clinics, and so maybe they're not so up to date on the latest recommendations. And so sometimes things do get missed or fall through the cracks. So by all means, send me an email and I'll make sure that that person gets seen at one of our colpo clinics. And so that's all I had today, if there's any questions.
Well, first of all, thank you so much for clarifying lots of queries. I still have 2 questions.
For sure.
So coming back to the basic indications for screening, on one hand, we say that the patient should be 25, and then the next line says, has ever been sexually active.
Right. But
Practicing in Mississauga, I have a wide variety of cases, as we all know. So I would think that what's the rationale? Like, for example, if somebody, and we do see patients who are sexually active since the age of 13.
Mm-hmm.
Now, we also know about the risk factors for HPV and the cervical cancer. So I still cannot understand that why we cannot get the testing for that population.
Yeah.
And then on the other extreme, when somebody is not sexually active, they are unmarried, and for cultural religious reasons, they cannot have a pap test. So where, as a family physician, if I am really try to be very good and provide the quality care, where do I stand in these extremes? And then the other thing is that would that be a good option if somebody is not sexually active and she's over 25 and we can still offer them self-collecting pap test?
So I think if they're over 25 and they really aren't sexually active and have never had like oral sex or, you know, shared a sex toy or anything like that, I really don't think that person needs to be screened. So if like a nun comes in and she's really sure sorry, maybe that's not a politically correct, but anyway, you know what I mean. You know, she does not need to be screened. Now, to your question about the 13-year-old who's been sexually active, and I mean, I think the natural history is that, you know, they should not get a cancer. And Ontario has looked at that data, and I don't think, you know, 13-year-olds having sex is new. And they have looked at their data over time, and there have, again, been very few who have had a cancer between 21 to 25. They might have an HSIL, they might have an HPV infection. That would most definitely be transient. So I have seen a couple patients in my clinics that they're 22, they have an HSIL. We don't treat it. We wait until they're 25, because if I do a leap on them, there is risks to that, right? Like not fertility, but you know, pregnancy risks. And so we really want to try not to intervene unless we have to. Some of those HSILs can regress on their own, and I've seen it happen. So that 21 to 25 age range, those HSILs, they can regress. Dysplasia can take care of itself sometimes. So that's why we don't start until 25. They are probably going to be HPV positive. So yeah, did I answer all your questions?
I don't want to be
There's one at
cheating
the back,
just because
too.
I happen to be sitting here.
Yeah, I think she had her hand up, and then we can come here. Yeah. Whatever's easier.
I really appreciate you touching on the patient education piece, because it's really struck me the panic is very different than you've had an abnormal pap test
Yes.
versus you are HPV positive.
Yeah.
And I'm curious what is on those letters, and can we extend that same, like I've had patients practically call a divorce lawyer by the time I can
wow.
get to them.
Oh, wow, yeah.
And so I think it's so important that we reach them at that letter in terms of like frequently like ask questions, or what does this mean? Yeah.
Do you mean the correspondence letter that they're getting?
Yeah, that
that's
says-
something that we can take back. Actually, there's several members of our Ontario cervical screening team are here, so they're hearing you and they're taking notes. So that's actually a really lovely idea. That, you know, what can we do better on that correspondence letter? So we can take that back. But these videos are not. These were made as part of our regional cancer program, as part of like a THPQI project and a med student I had. So that's this is like pre my provincial role, but we can definitely take that back.
Perfect. Thanks.
Yeah.
Do we know from other jurisdictions internationally or other provinces what the uptake is for screening if they brought in the self-testing more broadly? Does it
Yeah.
improve the uptake?
It seems that in Australia, it definitely has improved. Actually, what they like, I think a lot of people might be very curious about like a mail-out test, and BC's program is a mail-out test. But in Australia, they found that wasn't actually a slam dunk, and so they're also still doing a lot of like in-office, not provider collect, but in-office kind of self-sample collection. When they first rolled it out, they just rolled it out to kind of higher risk populations, but in the last couple of years, they rolled it out to all people as being an option, and it definitely has improved their screening rates. Now, Australia is kind of like the gold standard of, you know, vaccination and screening, and they're doing an amazing job. So we learned from them quite a bit. But I think, and we learned also from our FIT program that like mailing out the kit is not always going to translate into a completed kit. So these are things that we're thinking about as we think about how are we going to roll out our program. And you know, more to come. I think options and choice are probably going to be key to our program implementation, and we'll just have to see what we can actually do and what we think will be successful.
A follow-up question to that is we have a gender-affirming care clinic
yeah,
in
amazing.
Holton, but it's not part of the pilot.
Okay.
And I'm not aware of the price per kit, but has any group, such as a clinic like that, offered self-testing to their
So there is
patients?
actually, it's really random, but it's my husband's cousin runs one of the LGBTQ clinics. She's a family doctor. She actually gave a talk. Oh, she gave us a talk at Colpo Day in 2023. Her name is Dr. Amy Bourne. You may have heard her give talks. She's written a book about healthcare and LGBTQ plus population. So she runs a clinic in Toronto, and they are part of the pilot, and it's definitely, like she said, it's like transformative. So for your population, unfortunately, if you haven't yet been selected as one of the sites, maybe we can take your name in case there's more expansion. We can look to offer it. In the meantime, you could offer the kit that's available from Life Labs that is a mailed out test, but it's not part of the program. But if you wanted to say you could do this self-collected kit, like Life Labs has a kind of private option. And I think there's another company that has a mailed out kit as a private option, but these are outside of our cervical screening program.
Thank you.
And I think there's a question here.
Okay, so I have a two-part question. I have a patient. She's 22. She had an abnormal pap test. She had like an LGSIL. This was before the screening program came in.
Okay.
She was supposed to repeat her pap, and then we switched over to HPV DNA. So I did do the HPV DNA question. So that was DNA. So my first question was whether I should have done that. My second question is, it came back positive for one of the non-worrisome HPVs. So technically, this is her second abnormal
Yeah.
result, but they said to repeat it in 2 years.
So technically, she should be referred, I guess, from like our guide. Like I know it's a bit confusing. That was the correspondence on the thing.
They said 2 years, so I talked to her. I said, do you want to go for Calpo or 2 years? And she wanted to come back in 2.
Yeah,
So
I think that's also fine.
That's okay.
Honestly, like before 25, you're right. Like you could have not screened at all. You could have waited to 25. That's also reasonable.
Oh, okay, so that was
Yeah.
my first. Okay.
Yeah, it's also reasonable. I don't think, I think it's a discussion with the patient at that point, but I think what you've done is probably fine. She's probably low risk. Even if she came into Colpo with an HSIL, I wouldn't treat it. I would just look and say, oh, you have an HSIL, come back, I'll look at it again. Like we're not acting on them before 25. I think there was also a question at the back, but if we have time, we can do this one and then the one way at the back.
Thank you for your presentation. Obviously, it was amazing. I just have two quick questions. I have a certain patient population moving from the U.S.
Okay.
So they have had LEAP procedure there.
Okay.
I don't have the documents
Right,
for them,
yes,
but
that's-
it's the verbals here say I had a LEAP a year ago or I
Yeah.
had a LEAP 2 years, and they
Right.
they do meet the criteria.
100%. Yes, they meet the criteria. So you just have to write it in
So
into the
because
referral form.
one of us rejected because
Yeah.
she didn't have it here.
So then I think you have to put the moderate. Depends what box category you picked.
I picked the
moderate, and it
one.
was rejected.
Because I thought maybe because they didn't have the documents or proof
Yeah.
in the centralized, that's why, because she had it abroad.
Yeah, I can't speak to that, but I mean,
But
it
I
sounds
just
like
wanted to
if you.
confirm that it's okay for us to do that if the patient has had a LEAP procedure abroad, not in Canada.
Yeah, I mean, if they
Yeah.
had a LEAP and they've come here and
Yeah.
you need to do an HPV test, yes. I mean, typically somebody who had a LEAP last year would still be in Colpo.
Yeah.
So it's fine if you repeated an HPV test. That would be appropriate to do. And I would definitely select the either the moderate risk or the one that says like discharge from Colpo or higher follow up after Colpo.
Okay.
Yeah. And sorry, there's just somebody at the back.
Just one last question regarding the self-kit sampling.
Mm-hmm.
It seems amazing. I was just wondering that can it be like in future? Can it be possible for us to have those kits as well? Because sometimes we have patients who are extremely anxious,
Mm-hmm.
who have a bit of vaginismus. They do not comply. They do not come in for the Pap smears because
Yeah.
of that reason. So if we offer them and they're anxious to do it themselves, so as clinicians, can we do those because it's a vaginal?
That's a good question. Can the doctor do the swab? I mean, technically, yes, of course you can.
But we would need to have that.
Yes, but you can't do it right now because
Yeah.
only pilot sites are able to do it. But I mean, sure, if you wanted to be the one to put the Q-tip in the vagina, you can do
This
that.
is coming from because in lots of patients, they don't
Yeah.
even want to do the simple vaginal swab
Yeah, but
They
I would
want us to do
definitely.
it.
Yeah, no, I hear what you're saying. I
Because-
mean, that's not the goal, but I mean,
Yeah, that's
if
not the goal. It's just for
somebody-
a small patient population, their anxiety, health
Sure.
anxiety, they're just for them, not for everyone.
Yeah.
There's something to think about, like if in the future.
Yeah, I mean, I
that's a
don't think you need to
possibility.
just ask permission. Just like click that it was self-sample, and don't tell anybody. Like it's not a. You're obviously trying to do what's in the best interest of the patient. So that's
Yeah.
there's
Okay,
somebody
thank-
at the very
thank
far
you.
back who has her hand up, and I don't know how much more time we have. One more question. Okay, one more question. Oh, sorry, this lady had her hand up for quite a long time here.
Come back to you.
Yeah, I'm so sorry. Oh, you can. The other question, you feel free to find me at lunch.
Thank you. So I thought this might be helpful for others as well. So I have a 55-year-old. She's only had one partner, her husband, who passed away last year. Her pap tests have always been normal. Would this patient, should she continue with her pap tests if she never has a new sexual partner? Or would you maybe recommend one HPV test? And if that was negative, could she stop screening? Or should
said
she
she's
continue?
how old is she?
55.
55. I would continue to screen her. Again, the natural history of HPV is that the infection might be there. So we are recommending screening up until 69.
Even
But-
if she's
Yeah,
been
I
with her
mean,
partner
if
since
you do an
18.
HPV test and it's negative, then the next one's going to be 5 years, and then she's probably going to have one more. So she's probably going to have two more in her life.
Okay.
Right, so I would
Thank you.
between 64 to 69, if they've had consistently negative, then you can stop, right? So,
Okay.
Yeah.
Thank you.
okay, so I think that's it. Thank you.
Thank you, Dr. Zegras. There's lots of questions, and Dr. Zegras is going to be around for a bit. And if you have any questions, or if you want to reach out to any of the team members for a follow-up, please do. And I also want to thank Tiffany for being at the helm as we transitioned from cytology to HPV. I still remember some of those evenings where you ordered Indian food, and late in the evening she was here helping us coming up with plans and program as we strategized. So thank you so much. And but having said that, she's made it very clear that she's available to us, and we're very lucky to have her leading the provincial team going forward. So thank you, Dr. Zegras. And we'll definitely want to have you back next year. Thank you.